Good morning, everybody. I'm Dr. Rajni. I'll be presenting today a case in the endocrine and breast surgery teleeducation session. The case today I'll be presenting illustrates diagnostic and management challenges in a patient with primary hyperparathyroidism in a patient with MEN1 syndrome. This is the roadmap for today's presentation, and these are the key highlight points for today's presentation. First, we'll look at the patient demographics and how the patient presented. We'll then move on with the diagnostic workup, the treatment planned for the patient, surgical intervention, the post-op course, and then we'll ground the case in the broader aspect of MEN1 and its management strategies, taking references from the literature. Our patient is a 36-year female homemaker from lower middle class family in Prayagraj. She presented with history of recurrent renal calculus since age of 16 years. There's also history of left hip pain after fall from height 6 months. She also gives history of nausea, vomiting, and pain abdomen since last 4 months. There is history of secondary amenorrhea since last 3 months and proximal muscle weakness since last 2 months. After she had sustained fall 6 months back, she underwent an X-ray which did not reveal any abnormality or fracture. Later on, with worsening of pain in left hip, she was advised to undergo an MRI which revealed a fracture left neck of femur. On further biochemical evaluation, she was also found to have hypercalcemia. She was then referred to SGPGI, Department of Endocrinology, for management of hypercalcemia. She underwent an left PCNL at the age of 16 years. Recently, she had undergone an left DJ stenting in January 2025 for similar pain of left lumbar pain and burning micturition. She also was advised left lower limb traction, which she is on since February 2015. There is history of 5 PRBC transfusions 2 months back. She is on TAP pantoprazole for epigastric pain since last 3 months. There is no other history of any chronic illness. However, there is history of renal calculi in 2 elder brothers. This provides a diagnostic weight to the case and increases the suspicion of hereditary syndromes. So with the background of fracture left neck of femur, bilateral clavicle, and left renal calculus with chronic pain abdomen and secondary amenorrhea, we went ahead with the clinical provisional diagnosis of MEN1. On general examination, the patient was bedridden with traction in the left lower limb with Karnofsky performance score of 50. She was moderately built and nourished with an BMI of 20.4. There was no neurocutaneous marker or skin lesion. The systemic examination, all the systems are grossly unremarkable except for the motor examination. The power in the bilateral upper limb and right lower limb was 4/5, and the left lower limb was immobilized with traction. On neck examination, there was no palpable lump. On further biochemical evaluation, the calcium level was elevated to the value of 14.3 mg per dl, along with elevation of serum alkaline phosphatase. Creatinine was marginally elevated, and there was also an elevation in lipase and amylase, suggesting resolving pancreatitis. On hormonal evaluation, PTH was found to be elevated with a value of 116.7 picomoles per liter in the background of normal to high vitamin D levels. With a suspicion of MEN1, workup for pituitary was also done, for which prolactin and IGF were estimated. Prolactin was elevated with the range of 8 to 0.6 MIU per liter, and IGF was normal. We then went ahead with ultrasound of neck, which revealed bilateral inferior parathyroid lesions. The right lesion was 22 into 17 millimeters inferior to the right lobe, and it was likely cystic parathyroid lesion. On the left side, there was a hypoechoic lesion measuring 19 cross 13 millimeters at inferior pole, and another lesion measuring 12 cross 11 millimeter again at the inferior pole. We then went ahead with MIBI scan to rule out any supernumerary or ectopic parathyroid adenomas, and there were multiple avid lesions in the neck. Two in the both superior and 2 in both inferior, and 1 in the suprasternal region. BMD also revealed a very low bone mineral density. On the lumbar, it was minus 3.2. At the neck of femur, it was minus 3.9, and the hip, it was minus 3.8, suggesting osteoporosis. For the pain abdomen, she also underwent an ultrasound abdomen, which revealed cholelithiasis, and along with it, a hypoechoic lesion was seen in the head of pancreas measuring 2 into 1.8 centimeters. To characterize the lesion, she further went ahead with CCT of abdomen along with thorax. In the CT scan of the neck, we could see heterogeneously enhancing lesion in the inferior pole of both lobes of thyroid, suggesting lesion of parathyroid origin. In the CT of abdomen, there was a arterial phase hyperenhancing lesion, which we could see here in the duodenal mucosa, and there were few other lesions in the head of pancreas and in the junction of body and tail of pancreas, which measured 20 into 17 millimeters. Bilateral adrenal gland was also found to be bulky. Left adrenal was more bulkier than the right. There was abnormal enhancement pattern in bilateral kidney with left nephrolithiasis and DJ stent in situ. So now with the diagnosis of PTS-dependent hypercalcemic crisis with resolving pancreatitis, hyperprolactinemia, and pancreatic neuroendocrine tumors suggestive of MEN1, we went ahead with the management of this patient. The hypercalcemic crisis was addressed with hydration, post-diuresis, and injection zoledronic acid. The calcium levels were brought down to 10.8 mg per dl. The prolactinoma was managed medically with tab cabergoline because the MRI pituitary was also advised, which was pending because of financial constraints. PNET also demanded evaluation, but we could not move ahead because the patient was on long-term PPIs for which the gastrin assessment was limited. We then went ahead with management of hyperparathyroidism, which is usually the first thing to be taken care of in a setting of manifestations of pancreatic neuroendocrine tumors. We had planned for a subtotal parathyroidectomy, and the patient underwent subtotal parathyroidectomy with transcervical thymectomy on 26th of March. Intraoperatively, there were 5 parathyroid glands which were enlarged and maroon colored. Both right and left inferior parathyroid gland were found in the thymic tissue. On the right side, 2 parathyroid were present inside the thymic tissue and both were enlarged. Bilateral superior parathyroids were adherent to the pharynx and esophagus. The left inferior parathyroid was sent for frozen section and was confirmed for parathyroid. The remaining 1 × 1 centimeter of the left inferior parathyroid tissue was left with marking clips in situ with intact vascularity. The remaining part of left inferior parathyroid gland was removed along with all other parathyroid gland, and cervical thymectomy was also performed. On gross assessment, the left superior parathyroid measured 2.5 into 1.5 centimeters, weighing 4 grams. The left inferior measured 1.5 into 1.5 centimeters, weighing 4.5 grams. The right superior measured 3 into 2.5 centimeters, weighing 5.5 grams. In the right inferior, there were 2 lesions measuring 4 into 2 centimeters and 1 into 0.5 centimeters, measuring 8.5 grams along with thymic tissue. Post-operative course of this patient was stormy. The patient was started on injection calcium gluconate on post-op day 1 along with oral calcium and magnesium supplements. The patient was also given supportive antibiotics and analgesic. The patient had complaints of epigastric pain, and amylase and lipase levels suggested acute pancreatitis. Following which, on post-op day 3, the patient developed dyspnea. The patient required BiPAP support and was managed in intensive care. She was also supported with injection albumin and injection furosemide. She required a PRBC transfusion, and DVT prophylaxis was initiated. Further in the course, she developed metabolic acidosis secondary to urosepsis and acute kidney injury. The creatinine levels were rising, and there was also hyperkalemia. The fluid and electrolyte management was done in consultation with nephrology. The patient was continued on antibiotics. The blood culture revealed no organism growth, but the urine culture had showed E. coli growth and some yeast-like cells. The patient was managed on similar lines, and on post-op day, by post-op day 10, the patient could be taken off BiPAP support, and the patient was shifted to ward with tapering doses of calcium gluconate, and it was eventually stopped on post-operative day 11. The patient was managed symptomatically further for complaints of fever on and off because of UTI. The patient was discharged on post-operative day 21 on oral calcium supplements of 2 gram and tab cabergoline of 0.25 mg twice weekly. The final histopathology reported all the glands to be parathyroid adenoma. The right superior parathyroid adenoma, inferior also revealed adenoma with thymus. The left superior showed adenoma and left inferior parathyroid adenoma with thymus. On post-operative follow-up, 45 days after the surgery, the patient was symptomatically better for lower limb pain and weakness. She has been advised serial calcium creatinine BMD estimation. She has also been planned for left DJ stent removal and left PCNL by urology team. Orthopedics intervention has been deferred till she achieves adequate bone mass density. She has been advised MRI pituitary for characterizing the pituitary lesion, which still remains awaited because of financial constraints. And she has also been advised genetic counseling for MEN1 gene and MEN1 gene evaluation. For the pancreatic neuroendocrine tumors, we intend to estimate the serum gastrin and chromogranin levels. She has also been planned for EUS and Rotanog PET scan, after which the management of this will be decided. Our departmental experience from 1989 to 2002, we have seen a total of 592 patients of PHPT, of which 572 were sporadic, accounting to 96.6%, and 20 were familial, accounting to 3.3%. Out of these 20 patients, 9 were of MEN1, making it 45%. After 2022 till today, we have addressed 5 more patients with MEN1, making it approximately 1 to 2% of the cases. Moving ahead with review of literature. The consensus guidelines gave us the definition of MEN1 as the individuals with a diagnostic genetic test or a parathyroid adenoma with pituitary NET or duodenoppancreatic NETs and a first degree relative with MEN1, or more than 2 endocrine gland tumors, that is parathyroid, pituitary or duodenoppancreatic NET, and negative genetic testing and no MEN1 family history. Our case had more than 2 endocrine gland tumors, hence we could diagnose this case as a case of MEN1, and there was a clinical basis for this diagnosis. In this case, there was multiglandular disease and a suspicion of gastrinoma and prolactinoma. However, we should not forget other manifestations of MEN1, which includes thymic carcinoid, bronchial carcinoid, gastric carcinoids, and adrenal cortical gland tumors, which could be non-functioning cortisol or aldosterone secreting. And other cutaneous manifestations of MEN1, which includes facial angiofibromas, collagenomas, and lipomas, which are direct pointer towards MEN1. In a patient with PHPT, when is the MEN1 evaluation recommended? In a article of Genetics of Parathyroid Tumors, Thacker had proposed that a patient with PHPT who is of young age, that is less than 45 years, with multi-gland disease and or with parathyroid carcinoma or atypical carcinoma, they could be advised for mutational analysis, for which MEN1 would be the first one to be done. But for in a case of MEN1 disease with a suspicion of MEN1, when should be the index case tested? The consensus guidelines says that in an index case which meets the clinical criteria for MEN1, that is 2 or more MEN1 associated tumor or diagnosis of familial MEN1, or in a suspicious case of MEN1 index case, they should go ahead with MEN1 genetic analysis. So after the genetic analysis of MEN1 has been done and the test for mutation reveals that the mutation has been identified, we have to go ahead with clinical evaluation with symptoms and sign of MEN1 associated tumors, biochemical evaluation with estimation of calcium, PTH, prolactin, IGF-1, chromogranin A estimation, and radiological evaluation of pituitary, abdomen, and chest. If the test results are normal, then rescreening clinically and biochemically should be done at 6 to 12 months interval and radiologically at 12 to 13 months. But if the results are abnormal, then we have to proceed ahead with further appropriate investigations. But in a patient with MEN1 suspicion, but there is no MEN1 mutation identified, we can consider it an occurrence of phenocopy, and mutational analysis of other genes has to be done, which includes CDC73, CASR, and CDKN1B. The surveillance has to continue for additional MEN1 associated tumors. First degree relatives have to be identified for clinical and biochemical evaluation, and asymptomatic first degree relatives should continue annual clinical and biochemical screening, and first degree relative with MEN1 tumor should undergo surveillance as per MEN1 mutation positive individuals. The recent French guidelines published last year also propose that MEN1 genetic screening should be included in the situation if more than two disorders suggesting MEN1 are present. So after the patient has been diagnosed clinically and also genetically, what is the way ahead? Should we move ahead with total parathyroidectomy along with autotransplantation or subtotal parathyroidectomy? And what should be the timing of such surgery in children or adolescent? And when should be the surgery preferred in symptomatic versus asymptomatic patient? This still remains a topic of debate. However, the clinical practice consensus guidelines suggest that subtotal parathyroidectomy as the initial treatment of primary hyperparathyroidism and MEN1. And total parathyroidectomy should be reserved for those with extensive disease, either at first or at repeat surgery. The parathyroidectomy should also be reserved for symptomatic hypercalcemia patient with MEN1, and asymptomatic patient should not undergo parathyroid surgery but should have regular assessment of symptom onset, at which time the subtotal parathyroidectomy with transcervical thymectomy should be undertaken. And also for the timing of surgery, it requires careful consideration and factors such as surgical experience, availability of facilities for long-term regular calcium monitoring, accessibility of calcitriol, and patient preference should be taken into account. In children and adolescents, since they are in the growing age and uh, hyperparathyroidism could affect the bone mineral density, the timing for surgery should be assessed on case to case basis, keeping in mind that the complications of MEN1 could occur early and sometimes severe also. The findings of ZES indicate parathyroid surgery as gastrin improves with correction of hypercalcemia. Further in this debate, there has been meta-analysis to compare the outcome in patients undergoing less than subtotal versus subtotal and subtotal parathyroidectomy. In this forest plot, we can see this forest plot depicts the comparison of less than subtotal with subtotal and total parathyroidectomy for recurrence of PHPT. Less than subtotal is 3 times more associated with recurrence of PHPT, whereas it is 76% less associated with permanent hypoparathyroidism. On comparing subtotal with total parathyroidectomy, the subtotal parathyroidectomy is 2 times associated with recurrent primary hyperparathyroidism, whereas it is only 75. It has 75% less chance of occurrence of permanent hypoparathyroidism. On conclusion of this, they again supported subtotal parathyroidectomy as a primary treatment of choice, surgical choice for the management of PHPT in MEN1 patients. Few group of surgeons have also previously reported the management of MEN1 patient with abnormality on only one side with unilateral clearance, but it has recently making its way into the French guidelines. The previous report, which said that if the unilateral clearance was offered to patients who had concordant system EB and ultrasound showing a single enlarged parathyroid gland, the rate of permanent hypoparathyroidism and recurrence disease was not statistically different between unilateral and subtotal parathyroidectomy. So for appropriately selected MEN1 patients, unilateral clearance could also achieve similar result as subtotal parathyroidectomy. The spectrum of MEN1 is incomplete without the pancreatic neuroendocrine tumors management. In our case, since this is a case of suspected gastrinoma, the ideal treatment as proposed by the clinical practice guidelines suggests that it is a surgical excision for tumor more than 2 centimeter, which has reported there has been improved disease related survival in tumors more than 2 centimeter. Whereas in patients with tumor less than 2 centimeter, surgery, a non-surgical management is recommended, which involves hormonal therapy with somatostatin analogs, octreotide or lanreotide. Other treatment options being streptozocin and 5-fluorouracil for disseminated gastrinomas, hepatic artery embolization, and administration of human leukocyte interferon. If the patient presents with Zollinger-Ellison syndrome in a background of MEN1, then a parathyroidectomy should be performed before any surgery for ZES. And if the biochemical evidence of ZES disappears, then only the patient can be followed up. If the ZES still exists and the tumor is less than 2 centimeter, medical management could be offered. And if the tumor is more than 2 centimeter, either medical management or surgery with pancreatic or duodenectomy and regional lymph node resection could be done. The patients with MEN1 with other pancreatic neuroendocrine tumors, if it is an insulinoma, again a surgery can be advised if there is no metastasis, and in non-surgical management in non-metastatic disease. In similar lines, VIPoma and glucagonoma could also be managed with surgical and non-surgical options. With this, I conclude my presentation and I invite any further suggestions on this topic.